Infection Control Officer and Director of Clinical Virology Research Program in the Department of Infectious Disease at the University of Texas MD Anderson Cancer Center in Houston, Texas. On behalf of CME Outfitter, I would like to welcome you to today's educational activity titled Novel Approaches to Treating CMV Infection in People Receiving Solid Organ or Hematopoietic Cell Transplantations. Today's program is supported by an educational grant from Takeda Pharmaceutical USA Incorporated. Today's activity is brought to you by CME Outfitter, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. Let me now introduce our faculty. Joining me today is Dr. Genoveva Papanicolaou, or known as Dr. Xenia Papanicolaou. She's an attending physician in the infectious disease service at Memorial Sloan Kettering Cancer Center and professor at Weill Cornell Medical College and Cornell University in New York, New York. Welcome, Dr. Papanicolaou.
Hello, Roy, and thank you for inviting me. It's a pleasure to be here today.
Thank you. I'm going to start with the learning objectives for today's activities, which are first, identifying factors that increase the risk of CMV infection. Second, recognize the impact of CMV infection on treatment outcomes for transplant recipients. And lastly, develop balanced treatment plan for patients with CMV infection or disease. Before we get to the exciting new data regarding the treatment of CMV infection, I would like to review with our learners the incidence and the risk factor for CMV infection and the impact of this on our patient. So let's start first with the incidence of CMV infection and reactivation and the burden of it in our HCT or SOT recipient. Xenia, I will start with you. Can you tell me a little bit about the incidence first and the impact that you see it in your patients?
Thank you, Roy. So I see stem cell transplant patients, and of course, the stronger risk factor is CMV seropositivity of the recipient. And so the incidence probably ranges between 40% and 80% or more, with the lower incidence in matched-related donor grafts that are unmanipulated, and the highest incidence in the highest mismatched grafts, such as cord transplants, haploidentical donors, or grafts that have been manipulated to remove T cells, so T cell depleted grafts, or those that have received T cell depleted agents.
Okay, yeah, and as we know, so I think CMV probably the most common and the significant complication after either SOT or HCT in HCT recipient, especially in recipient positive, at least for the HCT group, and in donor positive and recipient negative for the solid organ transplant. Now, with the CMV and organ disease, actually now these days, it's not that common, although it's still happening. It could be up to 6% in autologous transplant, or even 30% sometimes in allogeneic hematopoietic cell transplant recipient. But with the preemptive therapy or prophylaxis, which we'll talk about it a little bit later on, this incidence is now less than 10%, I would say, maybe around 6% for either group. What we worry most about CMV, it is not only the direct effect of CMV, I would say, on our transplant recipients, which is usually an organ disease, because you can start with CMV reactivation and then progress to an organ disease, meaning pneumonia. It may go to the lungs, or gastrointestinal disease when it goes to the GI tract, causing colitis, causing esophagitis, or even gastritis. Now, what about the indirect effect, Xenia, that you can a little bit enlighten us, which we really worry about because of the CMV being the immunomodulator virus?
Exactly, and it is about this indirect effect that we believe that actually survival of the CMV seropositive patients is worse than the survival of CMV seronegative patients, even with preemptive therapy strategies. And we believe that part of this discrepancy is due to indirect effects. So in the stem cell transplant population, which I am more familiar with, CMV has been associated with graft versus host disease, increased fungal infections, and those perhaps could be either related to immune modulation or related to myelosuppression and neutropenia due to ganciclovir treatment. Now, in the solid organ transplant population, our colleagues have shown, of course, that the transplanted organ is more sensitive to being infected by CMV, but also they see allograft rejection. They see an increased risk of vascular disease and atherosclerosis after heart transplant, and also some other comorbidities, including diabetes after renal transplant, which I'm not sure if this is related to immunosuppression or whatever, but certainly for sure CMV infection is associated with increased hospitalization and increased costs.
Yeah, absolutely. So we touch up a little bit about the risk factors for CMV infection. Let's start with the hematopoietic cell transplant recipient. What do you think will be the main risk factors that we look at that can predict probably CMV infection, disease in our ECT recipients?
So the strongest predictor is, of course, seropositivity of the recipient in the stem cell population, because it is really the endogenous CMV that reactivates after transplant. And we can think about risk factor for CMV as a continuum. So in the early peri-transplant period, the other additional predictors would be the type of donor. And as we said, that matched-related donor transplants had the lower incidence. The seropositivity of the donor, so for CMV positive recipients, a CMV seropositive graft confers some protection due to CMV specific T cells procured by the graft. Of course, conditioning regimens that have more T cell depleting activity are at higher risk. And the general level of immunosuppression. So for example, heavily pretreated patients with lymphoid malignancies are at higher risk even if they get matched-related donor transplants. Now, later, from day 30 to 100, the biggest risk factor, of course, is graft versus host disease and its treatment, particularly corticosteroids. And beyond the 100 days is really the immune reconstitution is driving the risk for CMV. If there is delay in T cell recovery, then, of course, the patient remains at risk, and we can see late CMV infections.
Yeah. No, this is a great summary. And I know we know this is different in solid organ transplant recipient, where patients receiving lung, heart, and multi-organ transplant have the highest risk. Kidneys usually have the lowest risk. But the biggest risk factor also in this patient population for CMV disease is serological mismatch between the donor and the recipient. Recipient being seronegative and donor seropositive, probably the highest risk for these patients after transplantation of having CMV infection, CMV disease as well. And late onset CMV infection may develop up to a third of the seropositive recipients as well. So this is a very nice summary of the risk factors. Now, additional risk factors of CMV infection, SOT, intense immunosuppression, same thing probably like HCT as well, acute rejection, because at that time you have to increase your immunosuppression. Same thing like in HCT where you have graft versus host disease, when your immunosuppression gonna go up, you're gonna put them on high dose steroid as well, in this patient when they get this kind of complications, I would say. Now let's move on and talk a little bit about CMV diagnosis. We know we've been able to detect CMV for a long time, but there are several ways to do that. So can you walk us through a little bit of different diagnostic assay that you've been doing, Zenia, at your institution at least?
Sure. So first we start with CMV serology, so checking IgG. And this testing starts really before transplant to enable risk stratification. And actually, CMV infection is the only infection, to my knowledge, that drives also donor selection. So if we have a CMV seronegative recipient, we try to find a CMV seronegative donor, and vice versa. In the unmanipulated grafts, if we have a CMV seropositive recipient, we strive to find a positive donor, providing, of course, that there are comparable HLA matches in the donor. Now, after we have determined if the patient is CMV seropositive or seronegative, we need to be able to monitor for CMV replication, right? Because CMV replication is something that for sure we need to treat, and to prevent disease and other adverse events downstream. And so for that, we have now molecular quantitative assays. PCR is the most common assay used throughout the United States, at least. And the advantages of PCR is that the turnaround time is fast and provides really a quantitation. So you know if the patient is responding to therapy, if the patient has cleared his viremia, and so that's quite useful. But CMV PCR doesn't tell us anything about the immune status of the patient, so the ability of the host to control CMV. And there is where we have the CMV-specific T-cell immunity assays, which have not been yet used as a routine standard of care, but it's a very exciting field where you can actually assess the presence of CMV-specific T cells, and thus perhaps the ability of the host to control CMV.
Yeah, and I agree. I think it still have a role to, it has a role in our management of CMV infection, and we try to identify exactly when this tool or extra test will help us at the bedside, taking care of this patient. Especially with this highly sensitive molecular test that we have, and we have detectable CMV, DNA in the plasma or whole blood. Do you need to treat or not? Perhaps CMV-specific T-cell assays can lead us or help us to determine treatment or no treatment, or even stopping prophylaxis or putting someone on secondary prophylaxis after the course of treatment for CMV infection. So we touch up a little bit about preventive strategies, and we know we have two types of strategies, right? We have either prophylaxis or preemptive therapy. And the difference between the two, prophylaxis is you put someone on an anti-CMV drugs or agent during the high-risk period, when they are at high risk for CMV reactivation. These patients you identify by risk factors, you put them on this drug to prevent CMV reactivation. Preemptive therapy, actually, the difference is you monitor CMV in the blood by molecular assays, usually, because you want sensitive tests. And if it is positive, you start treatment. You start treatment for a short period of time. As soon as they become negative, you go back to preemptive therapy or to monitoring again. So this is two different between the two. But there is a pros and cons between the two strategies. Can you tell us a little bit, Zenia, about what really the cons between the two? Why you prefer maybe another strategy versus another one, at least in hematopoietic cell transplant recipient first?
So we think of these strategies really as complementary. So a preemptive strategy, of course, has the advantage of preventing completely CMV replication or clinically significant CMV replication, and thus alleviating the need for a preemptive therapy that even with preemptive therapy, sometimes we have development of resistant or refractory CMV. We can still see some CMV disease, and we can still see some mortality, albeit rare these days. With prophylaxis, of course, we prevent CMV replication, hopefully, until the patient's immune system is strong enough to control CMV on their own. And of course, that hinges on the recovery of CMV-specific T cells. And the con of the prophylaxis is that you need to provide treatment to all patients at risk, and thus you would actually give treatment to more patients than they actually would reactivate. Now, of course, with high-risk patients that their incidence of reactivation is so high, providing prophylaxis it's not a very big leap, right? If normally 80% of your patients would need preemptive therapy, then providing prophylaxis is just an incremental, just a smaller increment. With preemptive therapy, of course, you target treatment to only patients that need it, so that have active CMV replication. Unfortunately, with preemptive therapy, we have to deal with toxicities, particularly with the drugs that we had until recently, so namely ganciclovir and foscarnet. So ganciclovir and its oral prodrug valganciclovir cause frequently neutropenia, particularly when they are given early after transplant or when they are given for prolonged time. So it's a dose-dependent neutropenia, and it's up to 30% in certain series or higher. With foscarnet, if neutropenia develops or if patients cannot receive ganciclovir for any reason because they are refractory to, our alternative has been foscarnet. And that also is extremely cumbersome to give. It's given intravenously. It requires very intense monitoring and replacement of electrolytes. And causes kidney injury. So thankfully, we do have a newer therapy, which we're going to talk about. But until very recently, these were the two drugs that we had, and these are the disadvantages. And of course, if you have refractory CMV to any or both of these drugs, the alternatives were extremely limited or none.
Yeah, I totally agree, and this is interesting. Now in SOT recipients, the approach are flipped actually, because our colleagues who care for our solid organ transplant recipients have been using prophylaxis for a long period of time. And I think the reason is because we have an available oral drug, which is valganciclovir, the pro-drug for ganciclovir, that could be used on the outpatient for prevention of CMV or prophylaxis of CMV infection in solid organ transplant, where in this patient, we don't worry much about neutropenia. They don't have a weak grad that we see in the hematopoietic cell transplant recipient, although we know that the incidence of neutropenia could be high enough to be, to stop the drug, but it is probably a little bit better tolerated in our SOT recipient patient than in HCT for sure. But we know also there is a hybrid approach, starting with prophylaxis, then you can go to preemptive therapy. And always the struggle, I think, based on what I hear from our colleagues for prevention of CMV and SOT recipient is what the duration of prophylaxis as well, or even preemptive therapy. Are we delaying CMV reactivation? Because then as soon as you stop your preventive strategies, are you going to start seeing CMV disease or not? So the durations keep on increasing, over time in order to prevent this serious complication after a solid organ transplant, same like in ECT as well. Now, we talked about treatment, about prevention. So let's talk about the drug. The drug that either we have it, they've been on the market for a long period of time, and the new one that were recently FDA approved, for CMV infection, either prevention or treatment. First, as you see in the table here, we have different drugs against CMV where had different mechanism of action. And this is important because we always worry about cross-resistance. For letermovir, which is work specifically on the terminus complex of CMV, UL56, UL89, and 51. It's an oral drug, but it's available also intravenously. It is approved for adult who after stem cell transplant actually were recipient seropositive and for prevention. So here we're talking about the first drug actually been approved for more than few decades to prevent CMV reactivation after hematopoietic cell transplantation, at least in, it has different mechanisms of action of the available drug. Now, ganciclovir, valganciclovir, foscarnet, sadovir, even valacyclovir, they target the CMV DNA polymerase. So this is the end product, what they do. So you can imagine with these drugs, you may get cross-resistance. So if you have specific mutation to one drug, it may also give resistance to the other drugs as well. And then you talked about the limitation of using this drug because of toxicities actually that we've been experiencing for many years now, using this drug to treat either preemptive therapy as a preemptive therapy or even resistant and refractory CMV infection. Now, the last drug that was recently approved now it's been a few months ago, which is maribavir. It's also have specific mechanisms of action. We'll talk about it later on more, but it's an oral drug and it is specifically approved so far for for adult and pediatric patient actually, age 12 and above. For treatment of CMV infection which is resistant or refractory to therapy, to conventional therapy that we've been using for years. So we know there's limitation of CMV treatment for the drug that's been available for years, maybe toxicity. You talked about myelosuppression for ganciclovir and valganciclovir, nephrotoxicity for foscarnet, or even cidovovir as well. What we need to keep in mind is the drug-to-drug interaction for letermovir, probably, and we'll touch up on side effect of maribavir later on. So can you tell me a little bit, Zenia, about refractory and resistant CMV infection and really how we define it? Because we have to make sure we are all on the same page, especially in clinical trials, in outcome research studies or epidemiological study. Are we comparing apple to apple or oranges to oranges in this patient population when we talked about refractory and resistant CMV infection?
Yeah, thank you, Roy. And you, of course, spearheaded this effort along with other colleagues to really provide definitions that have been extremely useful for clinical trials and comparing outcomes. So let's start with resistant CMV infection that is a little bit more clear. So resistant is the presence of specific mutations that confer resistance to one or more anti-CMV drugs. Now, that is not sufficient, though. You also have to have a lack of clinical response to be defined as resistant. So refractory CMV infection is a term that was actually generated out of our clinical experience, that there are some patients where despite appropriately dosed antiviral therapy for at least 12 weeks, they do not have a virologic response. On the contrary, their CMV viral load continues to increase. And for the purposes of clinical trials, I think the definition is more than 1 log increase in viral load after 2 weeks of appropriately dosed antiviral therapy. So this is the definition of refractory. And of course, resistant is the addition of known resistance mutation conferring resistance to one or more drugs.
Yeah, and as we all know as well, Zenia, that refractory is probably much more common than resistant, right? Especially in HCT recipients, where we all face at the bedside with challenging, CMV infection, where with the absence of mutation, patient don't respond to the available drugs as well. So let's move on and talk a little bit about the risk factors for resistance in CMV. We know there's host factors that can, put patient at risk for resistant CMV infection. Profound immunosuppression. We know that even, when we dose the antiviral in suboptimal doses, and the reason we do it sometimes to limit the toxicities, this can put patient at risk for developing CMV resistance, having poor compliance with the preemptive therapy as well, or even poor absorption. So these are the host factors that can, risk factors that can put patient at risk for CMV resistance. Now, viral factors, initial high viral load, we know from few studies that if you start with very high viral load, you can predispose patient to resistant CMV infection, and it has to do with the viral replication kinetics as well. And we looked at mutations, as you mentioned earlier, by doing genotypic analysis to see which patient they're gonna fail therapy because they have specific mutation to a specific drug, which confer resistance to these drugs as well. Now, we know there is common mutation, known mutations, or what we call canonical mutation that confers CMV resistance in patient after at least hematopoietic cell transplant, but also same mutation probably in solid organ transplantation. Letermovir work on the terminus complex. So most of the mutations that we see conferring resistance are going to be on UL56, maybe some on UL89, and you see listed here, there's many mutations that are confirmed to provide resistance or to confer resistance to CMV. Maribavir work on UL97, as we mentioned earlier, and specific mutation on UL97 confer resistance to Maribavir. But what I want to caution everyone is there is specific mutation where on UL97 can confer resistance to both Maribavir and ganciclovir or valganciclovir. Same thing for ganciclovir and foscarnet. There is specific mutation conferring resistance to both or even to cidovavir. So you have triple hit here. Specific mutation where you can get resistance to ganciclovir, valganciclovir, foscarnet, and cidovavir as well. Now, let's move on and talk a little bit about the new approved drug, which is Maribavir, for treatment of resistant and refractory CMV infection. Zene, can you tell us a little bit first about the mechanism of action of Maribavir and the data behind phase 2 trial that I know you led a few years ago, looking at try to treat resistant and refractory CMV infection in hematopoietic cell transplant and solid organ transplant recipients.
Thank you, Roy. Yes, I'm very excited to speak about Maribavir. We've been having clinical trials for Maribavir for the last 20 years almost. So it is exciting to finally have it for clinical practice. So Maribavir also has a novel mechanism of action. Unlike the known drugs for treatment of CMV, does not target DNA polymerase. The target of Maribavir is UL97, but it has a multimodal mechanism of action, and it prevents CMV in 3 ways. It prevents CMV replication, CMV encapsidation, and nuclear export of the viral capsid. So a very interesting mechanism of action. So initially in the phase 2 study, which was a smaller study, of course, than the phase 3 and open labeled, but randomized to, patients were randomized to 3 different doses of Maribavir because it was also a dose finding study, and enrolled patients with resistant and refractory CMV, which were either solid organ or hematopoietic cell transplants. In that study, 67% of the patients achieved undetectable CMV at 6 weeks, and all doses performed equally. For instance, the 400 BID, the 800 BID, and the 1200 BID. And this is something that we have seen in prior trials of maribavir, that there is not a dose response curve. Now, these patients were heavily pretreated, and about 1/5, 20% of the patients had recurrence of CMV on treatment. And of those that developed a CMV breakthrough on treatment, about half had mutations conferring maribavir resistance. Again, this was a phase 2 trial, and the patients were very heavily and very prolonged treated before going into maribavir. And after all, maribavir was discontinued at about 1/3 of the patients, and at about half was due to CMV infection. Overall, I think it was a very positive trial in this very sick population. And of course, this trial led to the design of the phase 3 trial that you are very well familiar with.
Yeah, and you're right, Zenia, that these patients, when they enter this trial, they had very complicated course of CMV infection, and very challenging for us, and they were heavily treated. And seeing this result actually make us really very hopeful, at least in the phase 2 trial, to move it to this phase 3 trial, that maribavir worked very nicely in these very complicated cases of CMV infections and disease as well. So yeah, based on the phase 2 trial result, we moved to the phase 3 trial, which is the Solstice trial, phase 3 double, randomized open label trial, where maribavir at 400 BID or twice a day was compared to investigator-assigned therapy, which could be ganciclovir, valganciclovir, foscarnoside, or even combination as well. So in this trial, actually, patients were randomized 2-to-1 to either maribavir versus IAT, which is the investigator-assigned therapy, and the primary endpoint in this trial was the confirmed CMV clearance on 2 occasions, 5 days apart, of negative CMV in the plasma at week 8. So this is the primary endpoint of the trial. Now, we had a key secondary endpoint as well, which is CMV clearance, but also symptom control, both at week 8, but if they were maintained till week 16 of follow-up as well. So let's dive in a little bit and show you the result of the trial. And first, for the primary endpoint, we see that maribavir performed much better than the IAT arm, which is the investigator-assigned therapy. Around 56% of patients on maribavir had met the primary endpoint, which is CMV clearance, at week 8, versus only 23.9% or 24% of patients on IAT, at a difference of 32.6%, which is adjusted difference, which was statistically significant as well. Now, Zenia, can you tell us a little bit about the key secondary endpoint, which is also very interesting data in this phase 3 trial?
Yes, so the secondary endpoint was clearance and symptom control at a later time point, and I believe it was at week 16. And as you can see, of course, less patients maintained this endpoint, but still more patients in the maribavir arm met this secondary endpoint compared to the investigator-assigned therapy. And of course, we need to remember that what is the substrate of these patients? And the substrate of these patients are heavily immunosuppressed, and if the immunosuppression persists after the treatment phase, which was 8 weeks, of course, it is predicted that you are going to see some late infections of the assigned therapy.
Now, yeah, this is a very good point, because we tend to forget that these patients who have this kind of infection, which is resistant or refractory infection, as soon as you stop the studied drug or the drug to treatment, they're still at risk, they're gonna have recurrent infection. And it's always happened, even in in preemptive therapy, even patients with no refractory and resistance, as soon as we stop preemptive therapy, they may have another episode of CMV infection. So it's not only one episode and that's it, we're done with it. These patients, they're still at risk, they're going to have multiple episodes. And that's what we saw in the Solstice trial. But still, when you compare maribavir, as you mentioned, to IET, it was the rate recurrence rate was much lower than the IET, I would say. And this would take me to the clinically relevant recurrence of CMV during follow-up period. After you stop the study drug, it was lower on the maribavir, 28% versus almost 37% on the IETR. So this was not unexpected, actually. That's why now we talk about secondary prophylaxis all the time. If these patients are still at risk for a recurrent infection, they probably need to go on secondary prophylaxis. Now, let me ask you a question about the specific population or the subgroup analysis that were done in the trial. Can you tell us a little bit about the differences between maribavir and IETR?
Right. So this was a first kind of a trial in the sense that it included solid organ transplants and stem cell transplants. We don't get the chance frequently to work with our SOT colleagues. And so, of course, one question is whether maribavir worked well in both transplant populations. And indeed, it worked almost equally well in the solid organ and stem cell population. And again, in every subgroup that was looked at, whether it was by the type of the investigator-assigned therapy, by transplant type, by the baseline viral load, or by baseline resistance to other antivirals, maribavir performed equally well in every subgroup. So very important. And one thing I want to point out is that when for the patients that had documented resistance mutations, maribavir performed better, of course, because maribavir addressed really the heart of the problem, the presence of mutations to other drugs. So overall, in all subgroups, maribavir performed better than the investigator-assigned therapy.
Yeah. No, absolutely. So now let's talk a little bit about maribavir safety. And this was, very important during the trial to look at the safety. And, what I want to tell the audience mainly is, that the most common side effect probably for maribavir is dysgeusia. And we knew this for years, actually. If you remember well, Zenia, when we used the drug for prevention of CMV long time ago in different trials, dysgeusia was also one of the main common side effects. But what is important and interesting, had no impact, that there were no side effects related to myelosuppression or acute kidney injuries or what we call renal dysfunction or other serious side effects, especially when you compare it to IET or investigator-assigned therapy, where the rate of neutropenia for cycloviral cancer was much higher, and the rate or the incidence of kidney dysfunction was much higher for patients who received foscarnet on this trial. So I would say, at least we know that maribavir, it is safe and does not cause serious side effects. Even for dysgeusia, less than 1% of these patients who had dysgeusia discontinued the study drug or maribavir during the trial. It was only 2 patients, if I remember well, who discontinued maribavir because of dysgeusia while on this trial. So still, even with dysgeusia, it is most of the time very well tolerated, and patient can sail through it when you treat the infection. So this is the main safety profile of maribavir. Now, let's move on to the recently published guidelines. Actually, Zenia, you led along with other colleagues and myself, for the American Society of Transplant and Cellular Therapy for treatment option for resistant and refractory CMV infection. I know at that time, when we put all this together, maribavir was not approved, and we didn't have the final result of the SOLSTICE trial. But we mentioned in the guidelines that it could be an option, but we could not grade it as an option to treat resistant refractory infection because it was prior to its approval. Now, in retrospect, let me ask you, would you see that maribavir should be a first-line therapy for resistant refractory CMV infection, at least after hematopoietic cell transplant, transplantation in this patient population?
Yeah, absolutely, Roy. I think that we were at a kind of a race because we wanted to get the guidelines out, and maribavir was at the late stages of approval, so we could not really recommend it with the evidence, but certainly after the FDA and the European counterpart regulatory approvals, maribavir should be first line for treatment of resistant and refractory CMV.
Excellent, thank you. So now let's talk a little bit about our own experience. We know, I would say, we took us more than 20 years, if not more, to get to this point where now we have two safe and effective drugs to manage CMV infection. First, letermovir. We all know for the past, now it's been 4 to 5 years where it was approved for prevention of CMV infection in adult after allotransplant, allogenic transplantation for prevention. And we know the real world data looks pretty good. Now, recently, maribavir. So let me ask you, what's your experience, maribavir? What you doing at Memorial Sloan Kettering when it comes to resistant refractory CMV infection in your patient population?
So, Roy, as you know letermovir is used at our institutions for CMV prevention. So the resistant and refractory CMV that we see is much less than we used to see with preemptive therapy, and you have very beautifully showed that in your recent publication in CID. However, we do see some CMV infection, particularly in patients that have discontinued letermovir and have need for immunosuppression or delayed immune recovery. And there are circumstances that we have used maribavir in situations where the patients cannot use ganciclovir. If you remember, also in the clinical trial, there was a rescue arm that you could switch to maribavir if you develop toxicity from the investigator-assigned therapy. So this is a little bit of the label that says just resistant refractory CMV, but certainly I believe that patients that are intolerant or develop toxicity from ganciclovir, valganciclovir, we have used maribavir in these situations, or that patients that cannot really receive ganciclovir due to neutropenia.
Yeah, and this is our own experience as well, same as yours, where over the past few months, we use it at least on 6 patients who needed maribavir because they have refractory and or resistant CMV infections, and we have a great result as well. And hopefully, we're putting all this together, actually, at least try to share our experience with the real-world usage of maribavir. So thank you, Zenia, for the very interesting discussion and your input on this very complicated infection after transplantation. And let me start wrapping up a little bit. So today what we did, we discussed CMV infection as a significant problem after HCT and SOT as well. And we know recipient seropositivity for HCT are the main risk factors for CMV infection, and donor seropositivity and recipient seronegativity are the main risk factor for SOT recipient as well. Now we have different strategies, either prophylaxis or preemptive therapy. We have the hybrid approach for SOT recipient as well. And refractory as well as resistant remain a challenge for us. We know that this is, unfortunately, situation that we're gonna be seeing as we go, and we need to address it. And we are hopeful now that we have a safe and effective drug, which is maribavir, to treat this complicated infection after transplantation in SOT or HCT recipient as well. So I would like also to leave the audience with some SMART goals, which are specific, measurable, attainable, relevant, and timely. First, review patient and transplant characteristics in order to identify patient higher risk for CMV reactivation and or disease. Require genotyping or genotypic analysis when you suspect resistant or refractory CMV infection. But mainly consider letermovir for CMV prophylaxis in patients after allogeneic hematopoietic cell transplant and the right indication, and consider maribavir for treatment of resistant and refractory CMV infection or disease in patients receiving either HCT or SOT, because indicated for both patient population. Please visit the CME Outfitters Oncology Hub to access additional activities on relevant transplant and oncology topics, as well as resources and patient education materials. Lastly, to receive CME/CE credit for this activity, please click on the link to complete the post-test and evaluation. You will be able to download and print your certificate immediately upon completion. And again, thank you, Zenia, for your input and the discussion. And thank you to our audience also for joining us today.